Welcome to the Streets of Dublin Simon podcast. Here with me today is Eavanna Maloney. Eavanna is the head of clinical services at Dublin Simon. Eavanna, you're so welcome.
Thank you.
Thank you very much for joining us today. I'm really interested to hear all about your work and your career trajectory and the challenges you're facing in your work at the present time. So let's just start with talking about your career to date. Were you drawn to homeless services from the outset, or where did this journey begin for you?
So I actually was initially drawn to the respite stabilisation service, which was originally based in Usher's Island. It was set up in 2013 to support people living with HIV who were homeless. And I suppose my area of interest was around working with people who were living with HIV, because when I qualified as a general nurse in Ireland, there was an embargo on recruiting of healthcare staff. And so instead of going into the hospital system, I volunteered in South Africa for a year. And predominantly during that year, I worked with people who were living with HIV and AIDS. But I had actually subsequently been volunteering with Dublin Simon Community on their soup run, on the Sunday night soup run. And I had been doing that for about a year and a half. And the manager in that service told me that Dublin Simon had clinical services and that they employed nursing staff. And so I applied for a job in their clinical services in Usher's Island.
Okay.
So I worked in it was at the time the HIV respite stabilisation unit, and I worked there for over a year as a staff nurse, and then a manager's vacancy became available, and I applied for that role, and I was the manager in the respite stabilisation unit for 7 years. And then our clinical services, I suppose, expanded in Usher's Island. So we've been providing clinical services to clients who are homeless in Usher's Island since 2002 with the detox unit, alcohol detox unit it was at the time. And then broadened our remit to include the respite stabilisation unit. And after that, in 2018, we opened the Step Up, Step Down, which is an intermediate care facility for people who are homeless. So providing step down care from hospital and step up care from the community. And so a senior manager post became available over the clinical services, and I've been doing that for almost a year at this stage.
Okay, very good. So just for listeners who mightn't be familiar with some of the terminology, what does clinical services mean?
So clinical services means that we provide nurse-led services to clients. So in our clinical services, we primarily, I suppose, work with people who are in addiction, but we also address some of the complex medical needs that the vast majority of our clients would have. So, as I said, we started with our detox unit, and that originally was to provide alcohol detox and nursing care to people who were struggling in alcohol addiction. And what we have seen over the last 10 years really is a diversification of the substances used by people in addiction. So we are no longer really seeing somebody come through the doors who's just drinking alcohol. It's more so somebody's coming through the door, they might be drinking, they might be taking street tablets. And recently, an awful lot of our referrals into the detox unit might be drinking, taking street tablets. There might be cocaine in their urine, and there might be opiates or heroin in their urine. So we are definitely seeing that people trying to access our services are taking a much larger variety of substances than they would have been, say, 10 years ago.
That's really interesting then. So because you're working at the coalface, you have a direct insight into like the landscape of addiction. Why do you think there has been such a diversification of those substances? Is it like it's about availability, affordability to a homeless person? They can buy something for like a couple of euro. How does it come about, that diversification of substances?
Yeah, I mean, definitely, it would be naive of me to not say it's availability. There is a lot of availability of a wide variety of substances now that there wasn't 10 years ago, I would imagine. Um, I suppose, like, we would always look kind of, you would think it would be the UK, but we would kind of always look to the US and see drug trends and the trajectory of drug trends in America. And very often we would kind of brace ourselves to follow suit. So, for example, when crystal meth was really big in America, we were really bracing ourselves in treatment services for that kind of wave of crystal meth and the abhorrent complex medical needs that come with that. And we didn't really see it. However, when we looked at the crack cocaine epidemic in the US, we are definitely starting to see that wave here increasing, so that the numbers of people accessing our services using crack cocaine has exploded over the last, I'd say, 2, 3, 4 years. Um, and one of the ways that we're really seeing that in clinical services, because I suppose we're looking at the medical needs, would be the respiratory health of our clients. So that respiratory health has really deteriorated, and you can really see it. And I can see it in the streets, you know, when we're based at the moment up in Gardiner Street, and we would have a lot of people living in hostels and hotels on Gardiner Street. And you can hear it in people that are walking past you, the shortness of breath, the rasp in the breathing. And we would have an awful lot of clients presenting with, like, you know, after very acute chest infections. Our clients would have had poor respiratory health anyway from rough sleeping, smoking, but that has really exploded. So the vast majority of our clients would need support and medication now for the respiratory health.
Right. So addiction is one of the, I suppose, the primary factor in the poor health of clients coming into clinical services. Is that correct?
Addiction, and then I suppose the nature of rough sleeping, the nature of moving from one accommodation to another. We have done a piece of research recently in the bloodborne virus unit on adherence to HIV medication in the context of homelessness and addiction. And I suppose it looked at how obviously addiction, the use of substances, the lack of inhibition that comes with the use of substances, also the immediate gratification that's associated with taking illicit substances. So when you're taking your HIV medication, or when you're taking medication for a chronic illness, you don't get an immediate fix. You know, you don't have COPD and you take your inhaler on day 1 and on day 2 you feel amazing. But with illicit substance misuse, when you inject heroin or you smoke crack cocaine, you have an immediate hit there. You have an immediate result, an immediate fix to maybe an existing problem. So it's very difficult for people in addiction, I think, to take and then adhere to a medication where they're not feeling any results. Obviously, the fact that if somebody's in addiction, I suppose we explored the hierarchy of needs, and the need to get that instant gratification from a substance far precedes the need to take medication. So it kind of is very high up on their hierarchy of needs to get substances, to take substances, and to start that cycle all over again. And then the impact of homelessness on trying to adhere to medication for chronic illness. So obviously the nomadic nature of people in homelessness, as in they move around the place, they move from one hostel to another, there's no sense of stability. One of the respondents said, you know, you go in somewhere for 6 months, you get settled, and then you're uprooted again. So that sense of being kind of wrenched from any sense of stability,
Sure.
it's very difficult to care for yourself, to take your medication, to go to your appointments, if you have no sense of routine and no sense of stability.
Absolutely.
So, yes, obviously, addiction in its own right has dire impacts on people's health, but also being homeless, having no sense of stability, has equally as dire consequences for health for people, I think.
So I was really interested in what you said about, like, looking to the US to see what's kind of coming down the track. Why is that?
Why is it? I suppose large population. I suppose they do seem to be ahead of us all the time in terms of trends. So I suppose it's good for us to look at them because it gives us a bit of time to kind of know what's coming down the pipeline.
Yeah.
You know, it's not, we can't be guaranteed. As I said, the crystal meth so far does not seem to have exploded at the same, ferocity as it has in the US. But definitely, y- it makes sense for us to look to them.
Mm-hmm.
Um, and I think certainly with the crack cocaine, we can see similarities now, and with fentanyl as well. So obviously, fentanyl is a huge issue in the US at the moment. Opiates in general, connected to overprescription or people being prescribed opiates and not being able to come down off them successfully. And so fentanyl or synthetic fentanyl, use of synthetic fentanyl is on the rise in the US, and we are starting to see that in urine tests of clients in services. We're not seeing people being overly affected or presenting with overdose. And so we think it's probably fentanyl is in some of the other substances that people are taking. So maybe tablets laced with fentanyl. But there's a sense that clients are unaware that they have taken fentanyl, but we are picking it up in their urine. So that's something that
Mm.
we'd be, quite concerned about in services.
When you let the client know that you've detected fentanyl, do they have an acknowledgement that that's a particularly dangerous substance, or not so much?
No, not really.
They don't
It's
have that
more,
awareness.
what we would just see is that they're saying, oh well, I didn't take that knowingly, and
Mm.
then, oh, that must have been in something else that I took.
I see.
Which I suppose is at one level nearly more worrying because it really emphasizes that clients don't know what they're taking.
Mm.
People are taking substances out there on the street, and they have no idea what's in them. And it's only if somebody does a urine test that they're getting, a semblance of what might be in them. And we do we have a urinalysis test strip that's, at hospital level, it's not laboratory level. So we only know a certain amount of what's in the substances that people are taking.
Right.
So that is quite concerning.
For
And I
sure.
suppose it's an indicator that fentanyl is here. So in one
Mm.
way, shape, or form, it has arrived.
Yes.
And we need to brace ourselves for that, I think.
Okay.
Mm.
Okay. Um. So that's very, very serious,
Mm.
obviously. So just in terms of then the wider kind of clinical service offering, um, does it work on a referral basis, or how does it logistically kind of operate?
Yeah. So all three services work on a referral basis. They all require a GP letter or GP input into the referral to clarify and make sure that the person is medically fit for detox or for time in a community based service. In Step Up, Step Down, we have two referral pathways, Step Up and Step Down. So, Step Down would be from hospitals, and that would usually be for kind of post hospital admission, convalescence, recuperation, or maybe support around medication management or wound care post a hospital stay. And then we have a Step Up referral pathway that can come from the community, and that is supposed to be to support people to access a hospital stay. So the example we would often use is, say, for example, if you have somebody living in a hostel who's trying to go into the hospital to have a colonoscopy, somebody living in their own home, that's quite an easy affair. You go to your GP, you get your prep, you take your prep, you have a lovely toilet there that's your own, and then you're ready the next morning to go in to hospital. In a hostel setting, it's not the same thing. You're going into chaos, you're trying to take this prep, you might be sharing a bathroom. It could be quite undignified, like it's a very different experience.
Mm.
So we would try and provide that safe, supportive space where clients have their own room and a toilet and a nurse to kind of support them to take their prep and explain to them about the procedure that they're going to have in a hospital. So it's to kind of to provide a kind of a buffer and a safer space to prep somebody. And then there are people who are going into hospital for, say, procedures, and they might need a workup. So they might need bloods taken, they might need some scans done in the hospital. Again, if you're in the chaos of homelessness, very difficult to get to adhere or stick to any kind of appointments. So we would have support staff in the Step Up, Step Down unit who could bring them to hospital appointments and again explain to clients what they're going to have done, and what that means for the procedure they're going to have. So it's really a supportive environment to support people to engage with healthcare in general.
Excellent. So you're a general nurse.
I'm a general nurse. Yeah.
What is the nurse's experience of working in clinical services with homeless clients? It's going to be a little bit different. So what are the considerations, say, for nurses interested in the sector?
And it's interesting that you asked that question because actually our nurse manager in the bloodborne virus unit, Samantha McKeewa, who I know you'll be speaking to later, has done a piece of research on general nurses' experiences working in the area of addiction. So one of the big issues in Ireland at the moment is there's no clinical nurse-specific masters for nurses to gain expertise or training in the area of addiction. So very often nurses come into this sector, and I did myself, with no experience working in addiction. And unless those nurses have family members or they know of somebody who's been in addiction, that is a huge learning curve for somebody. So that's a huge challenge. As well as that, I suppose in general nursing, you're very much orientated toward and trained in like acute medical care needs of patients, so the physiological care needs of patients. And yes, of course, as a general nurse, you would explore mental health, but it wouldn't be the primary part of your learning. So there's the whole area around mental health care, trauma informed care, that I feel our nurses do an amazing job with, our general nurses, but they definitely need ongoing and further training in the area of trauma informed care, mental health support. And I suppose we know in the sector now around dual diagnosis that you can't treat addiction without acknowledging mental health, and you can't treat mental health without acknowledging addiction. And so there is a necessity for all nursing staff who are working in addiction services to be trained up and supported and educated in mental health, addiction, and physical health. So it is a big learning curve, I think, for nurses working in the sector. And I think often nurses can get very siloed and stuck in the physiological care. So we're focusing solely on the wound care, and maybe if somebody comes in to Step Up, Step Down and they have a cardiac concern, I know as a general nurse myself, we're going to gravitate to the wound and the blood pressure and the heart rate. And so it's often left to maybe the project worker and the support worker side of the staff to kind of re-emphasize, well, hold on, we have loads of stuff going on with this person's addiction, and this person is using substances at the moment. And that kind of to link both sides of the team up in terms of like, you're supporting this client to manage a condition here, but actually if you don't support them to reduce their use or to address their addiction in any way, when they leave this service, they're not going to be able to continue to support their health needs themselves. So, it's an ongoing piece of work, I think.
So where do you start? You have somebody who comes in the door with complex needs or dual diagnosis. You've mentioned, people are using opiates and might be taking multiple substances at the same time. They may have an underlying mental illness and perhaps some kind of chronic condition on top of that. So where do you start? Is it like you get a multidisciplinary team together and everybody focuses on one aspect? But, what does that project look like?
Well, I suppose the place that you start is building rapport and building trust, and I suppose a relationship that's built on integrity with the client. Because to be quite honest, if you don't do that from the second they walk into the service, any other interaction really is lost. And I kind of really emphasize in services the point about making every interaction count. And that really, the biggest piece of learning that came from the research on management of medication and addiction and homelessness was that people remember, a bit like what Maya Angelou said, people remember how you made them feel. And if they associate healthcare with a negative experience with a healthcare provider, they're very unlikely to go further and engage again for any medical condition. So I suppose in our services, the most important first step is putting the person at ease and building trust and rapport with the client. And that is the multidisciplinary team and the client. So GPs, nursing staff, social care staff, project workers, the cleaner, the catering assistant down in the kitchen. And then we start building the picture of the client and trying to find out who this person is, who are the supports that this person has, if any, in the community, and what are their needs. And we try to build that picture very collaboratively with the clients. So our care plans are built with the client sitting beside us. Our risk assessments are built in collaboration with the client so that they know exactly what we're doing, and they have had the opportunity at several different points to share with us what their needs are, so that we're not just creating what we think they need, we're creating something that involves what they want and what they need. Um, so yes, I think I
That's
might have
great.
segued, but
No, absolutely. That's a great,
that's where you
great answer.
start.
Right. Okay. Excellent. Um, so let's talk about kind of a typical client, if that's possible. What would be a typical profile of the kind of client that you'd have in clinical services?
So I suppose a typical client for us would be somebody who is actively using substances and who has ongoing medical or mental health needs, or comorbidities. So it's usually somebody with multiple ongoing chronic illnesses. So it's usually something respiratory like COPD or emphysema. We would see a lot of clients coming through the door with diabetes, huge increase in that over the last 10 years, most likely due to alcohol use and poor diets. Um, and they might also have wound care issues because they may have been injecting and they need care around that. And then obviously quite likely to be sleeping in hostels or rough sleeping. So you're dealing with all of those needs. You're working to gain rapport and trust with the client. You're working with the client to, I suppose, take the space and the time to look at their substance misuse, and to decide if they want to reduce their substances, if they want to engage in a detox. And you're also working with clients to, I suppose, learn about the chronic conditions that they have, and prepare them to exit your service in better health and better informed and better able to mind their own health. So, for example, in the diabetes scenario, a huge amount of work that the team would do with the client is supporting them to learn how to check their blood sugars, how to administer their insulin, how to understand blood sugar readings so that they know when to administer their insulin, and then how to manage and how to have a semi decent diet while moving from one hostel to another, being reliant on, food that is provided to you, not that you're buying and cooking yourself. So there's a lot of nurse education and a lot of social care education. A huge amount of the work that is done. So, for example, an awful lot of the clients who access our step up, step down service are not connected with any services on the outside. So they might come in not registered, um, not getting any payments, not aware of any social services that are available to them. So a lot of the social care staff and the project worker staff in all three units would be setting people up to kind of survive in our society. So, filling out forms with them, getting them their PPS numbers, getting them passports, getting them medical cards, all of those things that I suppose you and I kind of take for granted, that are so difficult to attain when you're transient and when you don't have a fixed abode and you don't have a fixed address. And then we have wraparound supports in services, so client development, who provide kind of support and groups around life skills and well-being skills like meditation, journal writing, that kind of thing, to try and support the whole person, the holistic needs of the person who comes through your door. But the vast majority of our clients would have very complex medical needs and would have underlying mental health conditions and would be in active substance misuse. Our detox unit is now an alcohol benzodiazepine detox unit, and I suppose the goal of that unit is to detox all the way down to abstinence, with a view to moving into our recovery services. Our bloodborne virus unit is, I suppose, more low threshold, so we provide a reduce the use approach, and that's very much where is the client at with their substance misuse and what do they want to do. And some clients do reduce all the way down to abstinence, so using zero substances, and they go into further treatment or our own recovery services. But in step up, step down, we don't say somebody has to do something with their addiction. We manage people at all levels of addiction, and we just manage it from, I suppose, a health and safety risk management perspective. And that is so that people can access appropriate healthcare even if they are in the midst of addiction.
So you've touched on, say, respiratory illness is very, very common in the homeless population. And from my reading, entrenched homelessness from the point of 18 months onward, when you get to that stage, it starts to have kind of, you see a real deterioration in a person's health. Homelessness is terrible for your physical health. Would you be able to talk about that a little bit?
Yeah, so we know that people who are homeless die much younger than the general population. So when I would see somebody in services who's in their late 40s, early 50s, they will often present like somebody in mainstream society who's 70, mid 70s, leading into 80s. So you see the development and the progression of chronic illnesses. It's so much faster in somebody who's homeless. People who are homeless have poor diets. So they are, from a nutritional level, they are devoid of nutrients. So you would see all the things that occur when you have poor nutrition. So osteoporosis, skin integrity, like people who are homeless have far greater risk of skin breakdown and tissue damage and therefore wounds than non-homeless people. And obviously your risk of infection in said wounds is much higher. You don't have access to the basic amenities like a shower every day, clean clothes every day. So yes, and then you're out in the cold all the time. You're far more likely to be addicted. You're far more likely to be smoking. And so your immune system is suppressed constantly, whether or not you have acquired a bloodborne virus or anything like that. So you're far more susceptible to picking up any kind of infection. And all of that takes its toll on your body. So yes, homeless ages the population rapidly.
And then as a nurse, you're trying to help to turn around these circumstances for people, doing your utmost. You have people coming at it from every angle, and I can see how somebody might begin to feel burnt out working in the sector. You might have a client continually coming in and their condition is deteriorating in spite of all of the input and energy and resources being poured in. Then at the same time, obviously, some people will see an improvement and go on to lead healthier lives and have better outcomes. But how do healthcare workers working in the sector avoid burnout?
I think it's a big challenge. And I think in addiction, like the statistics for people who actually put down all of their substances and never pick up a substance again are extremely low. And that is across all facets of society. So when you add homelessness into that equation, the statistics are even lower. So we do see a lot of people coming through the doors multiple times, and it comes across in Samantha's research, and I'm sure she'll talk to you about it. That people do find that very demotivating to see people coming through over and over again. Um, and some of the ways that we try to address that for staff is by, first of all, making it really clear that actually this is not something that is unique to the clients that we are seeing here. This is addiction. This is the reality of addiction. It is extremely hard to get sobriety, and then it's extremely hard, if in fact much harder, to maintain sobriety, especially when you're in a society where you have to clamour and scrape and push and pull to get basic services like a roof over your head, to get into the workforce, to get into education. Like, it's extremely hard. But the other piece I think that we really try to emphasize in clinical services, and you said it yourself, is the little wins and the small achievements that we get for people. And very often what you will see in treatment services is we might have somebody coming in, and he might come in 9 times. And on the ninth time, it's like a light bulb. And it's like that person got it. And you can see, and they will tell you, every time I came into these services, I picked up little pieces. No amount of sober time and no amount of reducing your use is wasted time. It all accumulates, and it's all part of the stepping stones to a sober life. And we have seen that people come in multiple times and then they just get it and they stop using and they go into our recovery services, and they might slip and they might step 3 steps backwards and then have to take 5 steps forward, but they get it. And people walk out the door, and it's only really when you follow somebody's path, say they come into a clinical services, whether it be bloodborne virus unit or step up, step down. And sometimes it's actually when somebody has just seen them on admission and then they see them just before they leave, and this person looks completely different. They've been able to get their payment. They've not spent it all on drugs this week, so they've been able to go out and buy themselves some clothes. They've eaten well for 3 weeks. They've gotten sleep. They walk out of the place a completely different person just because they have not had to deal with the fear of living on the street. They've managed to eat a few meals. They might have reduced their substances a tiny